Good morning, good afternoon, good evening, and welcome to today's webinar. My name is Laura Ceci Galanos. I am the Executive Manager of the World Stroke Academy, the education platform of the World Stroke Organization that provides stroke education to health professionals worldwide. Now, it is with great pleasure that I'm hosting this educational activity today, together with the American Heart Association, on guidelines for stroke rehabilitation and recovery, with exceptional speakers who are sharing their expertise on the topic. A special thank you goes out to all our panelists who are contributing to this activity voluntarily without receiving any contribution. Now, before introducing today's moderator, today's speakers, and today's topic, let's have a quick look at some of the housekeeping rules of this webinar. We welcome any questions that you might have throughout the webinar, but we kindly ask you to use the Q&A box for those in your Zoom control panel. This is an accredited activity, and all instructions for you to claim the credits will be sent out after the webinar via email. You can, of course, use the chat box if you want to say hi or leave your feedback throughout the webinar. I also want you to know that this webinar is recorded, and the recording link will be sent out to you via email shortly after the webinar. And lastly, we kindly invite you to fill in the evaluation survey at the end, which will pop up on your screen. Now, without further ado, let me introduce today's chair and moderator, Professor Nick Ward, Professor of Clinical Neurology and Neurorehabilitation at UCL Queen Square Institute of Neurology in London, UK. Welcome, Professor Ward, and thank you very much for being here with us today.
Thank you, Laura. Thanks for the introduction. So welcome, everybody. Welcome to this joint World Stroke Academy and American Heart Association webinar, which today focuses on the very important topic of stroke rehabilitation and recovery. So we've got three internationally renowned speakers for you today. So firstly, we're going to hear from Professor Marion Walker, who is going to talk about the recently formed International Stroke Recovery and Rehabilitation Alliance. Marion is an emeritus professor of stroke rehabilitation at the University of Nottingham. She's an emeritus NIHR senior investigator in the UK and was awarded an MBE in the Queen's New Year's Honours List in 2012 for services to stroke rehabilitation and stroke survivors. In 2020, she was the recipient of the Lifetime Achievement Award from the UK Stroke Forum. She has particular expertise in the development and evaluation of complex interventions and has published widely on moving evidence from randomized controlled trials into routine clinical care. After that, we'll hear from Professor Julie Bernhardt, who will discuss early rehabilitation after stroke. Julie is a clinical researcher who's worked for over 30 years with stroke patients. A major focus of her work has been to identify and work to fill current knowledge gaps related to the early onset of rehabilitation through the conduct of high quality international collaborative research. For example, you will probably all have heard of the AVERT and the AVERT dose studies, looking at early mobility after stroke, which she conceived and ran. Julie's been instrumental in bringing together stroke researchers and clinicians all over the world through the Stroke Recovery and Rehabilitation Roundtable, and more recently, the International Stroke Recovery and Rehabilitation Alliance. Lastly, we'll hear from Professor Sean Savitz, who will address what is the evidence gap for current stroke rehabilitation guidelines and what are the gaps in our knowledge. Now, Sean is a professor of neurology and physical medicine and rehabilitation. He is the Frank M. Yatsu Chair and Director of the Institute of Stroke and Cerebrovascular Disease at the University of Texas Health Science Center in Houston. Sean's research focuses on stroke recovery, rehabilitation, and the application of cell-based therapies as an innovative treatment for stroke. He's been funded by grants from NIH, the Howard Hughes Medical Institute, and the American Heart Association, and is an author of over 275 publications in the biomedical literature. So there's a lot to look forward to from these three. Following this, we'll have about 10 minutes for discussion. And I just briefly wanted to remind you of the broad learning objectives that we've set for this webinar. Firstly, to be able to identify the benefits for rehabilitation after stroke, to be able to discuss guidelines from multiple organizations in stroke rehabilitation, and to be able to list ways to measure improvement in quality of movement after stroke. And now, that's enough of me. We're going to move to the first of our speakers, Professor Marion Walker.
Thank you, Nick. Just getting my slides up. There we go. Good afternoon from the UK to everybody who's joining us today, and I'm very pleased to be the first speaker in this stroke rehabilitation session. So this afternoon or today, what I would like to share with you is the thinking and the evolution of the new International Stroke Recovery and Rehabilitation Alliance, known as ISRRA. And this may be known to some of you, but I'm hoping that we get this word out and we get as much engagement from the stroke rehab and recovery community as possible. Now, these are my disclosures. So at the forefront of this alliance is Professor Julie Bernhardt, and Julie had discussions with us about forming such a group as this many years ago, as far back as 2016. And really she remains at the forefront of our work in this area, and for her leadership, we're extremely grateful. So if we're talking about rehabilitation and recovery, we really need to be clear on our definitions of those. And for recovery, they're often used interchangeably, but recovery reflects the extent to which the body structure, functions and activities have returned to their pre-stroke state. And whereas rehabilitation is a process of active change that brings the stroke survivor back to their optimal physical, psychological and social functioning. And this definition has already been published in the International Journal of Stroke. And throughout my talk, I'll give you the link for all the papers that I'm talking about today. So over my long career, there has been a particular growth, an exponential growth in recovery and rehabilitation research. So for example, we have more than 1,400 randomized controlled trials for the upper limb, and we have more than 1,000 randomized controlled trials for the lower limb. So you may be asking yourself, why do we need a new direction? Why do anything different? Oh, sorry, I'm just, my chat keeps obscuring the return button here. But the reason is that a number of barriers hamper our progress. So we have standardized terminology. We're not all on the same page with that. We poorly describe the methods of the research that we use. And even when we do have robust evidence, often getting this into practice is sluggish. We don't have well-defined recovery biomarkers, and we have a lack of consistent timeframes or measures to examine our outcomes. And this was also highlighted in McIntyre et al. In 2016, who looked at the quality of motor the trials for motor intervention, and found that although the quality had indeed increased, that there were still many barriers in existence, and that rigor needed to improve if we were to be producing evidence that was robust, meaningful, and that clinicians could implement in practice. Kathy Stanier also wrote a very interesting piece in the F1000 research. And again, she made the point that we needed to be doing something different if we really were to make a difference. So it's clear that the same old thinking will produce the same old results. And that's why so many of us, our global leaders in stroke rehab and recovery, got together to decide that we really needed to do something a bit differently. So a new way of thinking. And this took us forward to developing consensus statements through the stroke rehab and recovery roundtables. And this really was about developing consensus statements around the gaps and the thorny issues that were existing in rehab and recovery research. And this developed onto a series of roundtables. The first round table happened in 2016 in Philadelphia and produced a series of wonderful papers, which the link at the top of this slide will take you directly to all the papers and publications from the round tables. The second round table was also very successful. It was started in Montreal, and a third round series of round tables is currently underway. So this has produced some very much required information for the stroke rehab and recovery community. But it was clear we had to shift from just giving advice and consensus statements to actually having some action. So there was a real feel that there was a potential for an alliance such as ISRRA to develop a truly collaborative international community, so that we all got together and didn't work in our silos, and that we tackled these barriers together. That there was real potential for accessing international research funds and doing research that's really impactful for our patients. It was also, we recognised that there was the potential to develop support for research leaders of the future, the next generation of research leaders, and most importantly, to make a difference to our patients. But this requires action. But when we discussed these issues with other global leaders, there was a real feeling that this was the time that we had to press go and do something different. So there's clear benefits of global collaboration. It's about diversifying and thinking differently, thinking outside the box, about understanding each other's individual cultures differently, how stroke services, stroke rehab services can be different in different countries with different cultural backgrounds. It also allows a trust to develop between nations where there's a free exchange of ideas and where we can share our expertise, our knowledge, and the individual skills that we have. And as I say, about developing opportunities for career development for our researchers, our up and coming research leaders, and providing a unified voice for stroke rehab and to accelerate recovery, science and care. So with that in mind, 30 of stroke rehab and recovery research leaders across the globe got together in 2019 in Geelong in Australia. And this was a self-funded meeting where the leaders all got together to discuss this very idea of setting up this research and recovery alliance. And I think the fact that it was self-funded and the effort that many people made shows the commitment that there is to moving things forward. So after 3 very intense days working in this workshop, we managed to develop a 5-year strategy for ISRRA. So down the left-hand side of this slide, you'll see 11 individual milestones that we documented in this 3-day workshop. And I'm going to talk about one of them in a little bit, one of the milestones that I led about developing the criteria for aspirational centres of excellence. The middle bit of this slide highlights the strategic investments that we would have to make in order to achieve the outcomes here that we were seeking to achieve by 2024. And the outcomes that we wanted to achieve was that by 2024, we wanted to be the global go-to group for stroke rehab and recovery. We wanted everybody that was part of the alliance to share a joint vision that we had for going forward, that we weren't distracted and taken away from key drivers and levers for success, so that we kept our focus firmly on moving forward. and that we were delivering significant outcomes for people living with stroke. By 2024, we wanted to have developed a mature research capability, and we also wanted to be sustainably funded. So quite high ambitions. And as these slides will be available later on the website, you'll be able to ponder each of these milestones and outcomes. I have to say that our strategy is currently being revised, as good strategies are. They're a living document. So the executive group are currently revising this, but you can see where we were up to in 2019. However, at the end of the Geelong meeting, we actually had a discussion around where we were today in achieving these aspirational outcomes and how big the gap was. So the red bars illustrate the gap of travel that we need to make. But I'm pleased to say that since 2019, we have made more progress, and there are more blue bars than there was in 2019. But because we wanted this to be an inclusive alliance, we advertised a launch of discussion around ISRRA in September 2020, and this meeting was advertised widely across the globe. We had more than 80 participants join us, and at this meeting we introduced ISRRA, we introduced the vision and the goals that we had, and we talked about the working groups that were ongoing. And as we talked about each of the working groups, we asked the membership of the attendees to tell us what was good about it, what was missing, and what we needed to change. But what was overwhelming at the end of the meeting was that there was a real endorsement for the areas of action that we were taking, and there was a real enthusiasm for the proposed structure in terms of reference that we had. And there was very major encouragement for people to come on board. So I just want briefly to tell you about the Centres of Clinical Excellence. And the reason that we want to develop criteria for stroke rehabilitation and recovery centres of excellence is that we have a clear description of what centres need to aspire to, that enables them to benchmark how far off they are becoming a centre of excellence, and that it produces development and sharing of expertise. We had 17 members, rehab experts, take part in this working group, representing 10 countries. And we also included 4 patient groups from low and middle income countries, as well as UK and Australia. And it was great to have this input, and the work took place over 18 months. It took place over email discussions, online meetings. We'd already scoped the literature of how other sectors had developed centres of excellence, and we developed surveys, developing initial criteria where we refined the language that was used in the patient groups. And this methodology we used was Keeney's value-focused thinking. And this work is just about to be submitted for publication. In a nutshell, what we came up with were 7 ranked criteria that define centres of clinical excellence and recovery and rehabilitation. The top of the ranking was that we developed optimal outcomes for people with stroke and their carers. And that means health and social as well as well-being outcomes. That each centre had a highly developed research culture, that teams were all working together with patients and carers of stroke survivors, and that they were all working to joint goals. That there was clear knowledge exchange demonstrated in centres of excellence, and that could be through sabbaticals, through taking part in surveys, etc. That there was strong ethical leadership, excellent education in these centres, both in-house and masters, PhDs, etc., and that there was real advocacy for equality in service acquisition. So as I say, this hopefully will be in the published domain soon in more detail. And the next steps are for us to operationalise these criteria through developing key performance indicators. And I'm working with Rachel Stockley and Elizabeth Lynch to lead this work, along with the expert groups and consumer groups. We're all working in partnership to progress this. So anyone can become a member of ISRRA. It's currently free, but our expectation is that you will, if you join, you will contribute to open and transparent discussions, that you'll come to our meetings, that you will have an opportunity to develop further work plans and to develop new collaborative working groups, and that we work collectively together to push forward the recommendations from the roundtables and to deliver the vision that we have set out for ISRRA. So if you have any queries about it or to join, please, this is the email to contact us on, or admin@strokerecoveryalliance.com. So if we're really serious about moving stroke rehab and recovery forward, we really have to harness this global enthusiasm or knowledge and collaboration. It really is the way forward. And I'd like to thank you for your attention and listening to me today. And I'll hand over to Nick again. Thank you.
Thank you, Marion. Just before we hear from Julie, I just want to point out that because of the significant time difference between this webinar and Melbourne in Australia, that Julie has pre-recorded her talk. Nevertheless, we're still very happy for you to post questions in the Q&A. Julie has offered to answer all questions that you post by email, unless one of the other panelists can try and deal with it for her. So let's hear from Julie.
Hello, I'm Julie Bernhardt, and I'm going to be talking to you about early rehabilitation after stroke, research and practice. My disclosures are shown on this slide. Over the course of the next few minutes, I want to talk about the rationale and evidence for early rehabilitation, pointing out both what we do know and what we don't know, and then tell you a bit about what we know about current levels of early rehabilitation, and then finish briefly by talking about our early mobility training trials and what impact that we're hoping to gain from running these studies. But I think it's really important that we frame this conversation by thinking about what the opposite of doing something is. And doing early rehabilitation, or the opposite of that, doing nothing, is actually bed rest. So we know from, and have known for a long time, that bed rest can lead to very rapid changes in muscle and cardiovascular change, but also that it leads to another number of other consequences that can have a negative impact on someone's ability to recover after surgery or injury or stroke. So as Chris Allen and colleagues put it in their seminal paper in 1999, bed rest is a potentially harmful treatment that needs careful evaluation. And of course, over the last 20 plus years, we've seen a lot of conditions where they believed that bed rest was good early, swap to having a very energetic and early approach to rehabilitation. And that includes in heart attack, in surgeries, and the list is actually quite extensive, including in intensive care rehabilitation. Now, I won't have time to cover that today, but needless to say, there's been quite a shift. And so we need to think about what early rehabilitation means to us. Well, we have talked about early timing being favoured for quite a few years. We're not sure exactly what the optimal window is, but we certainly think that from animal studies, we can tell that there is a lot of change that happens in the brain early after stroke, that there is potentially an important period where there's growth promoting hormones peaking around 7 days. We know that the architecture and dendritic spine architecture changes rapidly as well. So have a look at these papers by John Krakow and the book by Krakow and Carmichael, which is a very good book called Broken Movement, to have a look at some of the information that we have at our fingertips around what happens soon after onset of stroke and stroke injury. So we see learned non-use and learned disuse really early after stroke. We know that if we want restoration, we probably need to really focus on the quality of movement and practicing movement early, not on compensation. We see later very fixed movement patterns, or what can be called maladaptive plasticity. This is quite common after stroke, including contractions that can start quite early. And of course, moving beyond just the physical aspects of recovery and rehab, we also see that there are changes in people's mood that might be improved by being active and getting going. But we don't know what this critical period or optimal window might be. And certainly if we look at some of the work by Dale Corbett and others also in animal models, that starting at 30 days after stroke may be way too late for recovery to occur. So should we care about this in humans? Well, of course, the work that we've seen in preclinical science tells us about the biology of stroke and stroke recovery related to behaviour change and behavioural interventions, and we should listen to that. But we're also starting to see in recent papers that it could be that there is this short and distinct time window for recovery. So I'm just going to point out 2 trials that have come out over the last several years. So this first one by Timoko Kitago and her colleagues is really showing that, in fact, when you track someone's motor recovery after they've had a stroke and do that on a regular basis from the time of onset, that motor control continues to modify for around 5 weeks after stroke and then stops. So is that the important window that we need to get into if we're trying to really enhance spontaneous recovery beyond what it might be? This other recent paper that just came out also shows that using, again, an upper limb model, that there could be this 14 to 30 day window where there appears to be greater neuroplasticity and therefore greater potential for recovery. So we have some evidence, it's small, but it looks like starting early is good for our recovery. Now, when we talk about early, we encourage people to use these definitions, which come from the work of the Stroke Recovery and Rehabilitation Roundtable, the first one. So when we're talking about acute, it's 1 to 7 days, early subacute, 7 days to 3 months. We're not sure exactly how early might be too early, and also how long this period of enhanced recovery might continue for. But certainly it's something that we need to learn more about. Importantly, this is not to say that applying treatments late after someone has had a stroke might not be beneficial. And in fact, there's a lot of good evidence that we can make changes happen, but that's not what I'm covering in this talk. So coming back to the timing part, well, as some of you may know, we ran a large international trial called AVERT that was published in 2015, looking at early mobility training. And this started within 24 hours of stroke onset. And in fact, our finding was that too much mobility training too soon can actually lead to worse outcomes in the intervention group compared to lower dose usual care. It's really important that we think about not just the timing, but what the intervention package also consists of. I'll come back to that. But there was also a study that was published in 2020 by Erin Gadecki looking at speech and aphasia therapy that also was looking at different doses and early onset of training. And they weren't able to show that this earlier onset of more training led to a better outcome. But there are very few studies in this space. So these are all important steps in our learning. So as I said, I'll come back to AVERT a little bit later. But let's turn to what's happening in hospitals. Now, this was a review article that was published in 2016, but is looking at acute hospital settings. And as you can see from this slide, that the mean upper limb therapy per day, which is the focus of this study, is extremely low. So varying from, a few minutes a day to a maximum of around 15 minutes in one site here in the US. So the answer to that question, and I think we can be sure that this has probably not changed a lot, even in the last few years, that it's not much therapy that people are getting, and it's probably not enough. In 2013, we saw this nice paper by Han et al. That looked at people with severe, moderate and mild stroke. And if we look at this acute, so the earlier time point after someone's had a stroke, and mean gains in Fugl-Meyer, so impairment, looking at whether or not they're making a change. And if we acknowledge that the generally agreed benchmark of improving on 6 points or more as an important threshold, what you'll see here is that it's 2 hours a day, 3 hours a day, where we start to get really important changes happening in these studies. And that's very different to 4 minutes a day. So if we have a look at this more recent review that was done by Kate Hayward and her team, that included 288 clinical trials of arm training. So now we're talking about what researchers and clinicians are choosing to put into trials. Now, this is focusing on studies that are within 6 months after stroke. And as you can see here, included studies that had over nearly 10,000 patients in the trial. So go and have a look at this study. But the main thing I want you to take away from here is she was looking at a minimal clinically important difference between the groups, and that gives you a tick. So were these studies successful in creating a difference between a control arm and an intervention arm? And there's a lot of other information that's buried in here, but the most important thing to look at is when we talk about 120 minutes a day of training, even in these research trials, did many of them have that? And you can see the small number of ticks that are shown here. So this is just one little snapshot of the whole lot of tables that you can find in this review. Again, though, we can look at the average, which is about 30 minutes a day in these trials, and we can say that that's not much and probably not enough. So just going on to early mobility training. So in the AVERT trial, we were looking at doing 120 minutes of training, up to 120 minutes of training per day. And this for some individuals was absolutely too much. And what we've seen since this trial is we've completed the Cochrane review again in 2019 that was led by my lovely colleague Peter Langhorn. And there are 9 additional early mobility trials in there, but still no evidence, no clear evidence of harm or benefit. Some of the AVERT results get washed out with these, the addition of these other studies. But what does this mean? Well, it means that AVERT did actually lead to clinical practice guideline changes. And quite rightly, clinical practice guidelines changed and vary. Many do caution a very early start, so don't start within 24 hours. but very, very few rarely recommend a dose. So while being told to not start at that time might be helpful, what we really need to know is what is the dose of intervention we should be providing. Now, if you want to look at the clinical practice guidelines and how they vary, I recommend Venetia Rethnam's work to you. But what did this mean for us? This left us wondering, well, how can we help support clinical decision-making around early rehabilitation for mobility after stroke? And so we took the information that we had acquired from the 2,100 patients in AVERT and created the AVERT dose trial. And its primary goal is to find the most effective and safe intervention to practice with people with mild and moderate stroke early after stroke. So starting within 48 hours of stroke onset. Because we found that people with ischemic stroke, with severe stroke, had a much more variable outcome, we think they need to be prioritised as individual treatment approaches, and the same is said for ICH. The regimens that we're testing in this dose finding trial are lower than what we put in to AVERT. So this is a MAMS CARA design. So it's a multi-arm, multi-stage, covariate adjusted response adaptive study. So it's these new adaptive trial designs, which is really interesting to conduct. And it means that we are informed as the study goes on with the outcomes of the previous participants, and that helps inform the randomisation schedule for our patients moving forward. So it's both potentially more ethical and safer for people to be under this design. So we've started this trial, it's running in 8 countries, and we really hope that we can help with the development of practical guidelines. And we know that the clinically useful early rehab protocols need clear information about who should be included in our intervention strategies, safety criteria, when they should start, how often per day, the amount, so the minutes per session, how hard someone is working, and then how do we tailor the treatments for our individuals over time. So my final thoughts in this early rehabilitation session is that an early start to rehabilitation is probably important, but rarely is intensive training delivered. Now, how early and how much needs clarifying, but that's a work in progress in many domains. And of course, we need to develop systems of care that support more intensive practice. And that's critically important for us to move from research into practice. So I just want to thank the many people who are involved in lots of work related to my content in this talk, and you can contact me right here. Thank you.
So just thanks, we'll say thanks to Julie in her absence. And just before we move on to Sean, I just want to remind everybody, there are some people who are posting some questions in the chat, which is fine. It's just sometimes it's a bit difficult to track that. So if you do have the opportunity and you want to ask a question, it might be easier for us to see the question if you put it in the Q&A function. So thanks very much for that. So now I'm going to pass you over to Professor Sean Savitz.
Thank you very much. I really am very grateful for the opportunity to give this talk. So you just heard a fantastic lecture about the importance of clinical trials to answer important questions in the field of recovery and rehabilitation. This talk is really raising the question about, so what are the guidelines that we have that, for instance, come from the American Heart Association and other countries like Australia? And what's the evidence and the data to support guidelines overall? So guidelines with respect to how they inform upon clinical care, ultimately, guidelines should be drawing upon the best data that is available. And of course, ideally, that data should be coming from large-scale, rigorous clinical trials. As Julia had shown with the AVERT study and the AVERT dose trial that she just spoke about. But when we look at the field of recovery and rehabilitation, in my opinion, it is an area where we are in great need of further trials and further studies, and we don't have the same level of evidence base as acute stroke or prevention. There is tremendous variation in care, and there are a few standardized performance metrics, I would say, at a global level, and that's something that we can see that Professor Walker is thinking about with her group, as well as what ISRRA is looking and planning to think about as well. But we really don't have, for those of us that work also in the acute stroke care environment, there is no equivalent door to needle, so to speak, door to TPA equivalent when it comes to rehab and recovery. And the interventions that are important and applied to patients, they vary in the type of care settings that they're used and their durations, the intensity, type delivered, just as Julie had mentioned. And of course, the degree of the involvement of specific specialists that come from various different areas of healthcare, medical, nursing, as well as other areas of rehabilitation. So I'm going to speak specifically to the guidelines, and I'll be referencing and specifically mentioning the American Heart Association's most recent guidelines on rehabilitation, as referenced here. But I thought it would also be important, since this is a seminar through the WSA, to choose a different country, and I chose Australia, New Zealand, the Stroke Foundation, and their guidelines, which is a living document, as demonstrated at the website shown here. And so there'll be some comparisons and some contrasts that are provided. So the first is this slide, which is a little bit blurry. It comes from American Heart Association guidelines in general. This is, in my opinion, really an excellent way of how to frame guidelines overall in terms of the level of evidence. And so there's two dimensions that are being shown here. There's really kind of on the, as you go across the class of evidence, as well as then there is the estimate of certainty, which is really the level of evidence. And the class of evidence really speaks to the magnitude of the benefit versus the risk. And that would be derived from various different types of clinical trials that are being analyzed overall. So you can see the highest level for class 1 is that benefit clearly outweighs the risk, and that the procedure should be performed. But as you go across the screen, you can see that there are other areas where don't have enough evidence to fully support benefits. So it falls into lower classes, even to the level that perhaps the studies have shown that there is no benefit or that there might be harm. And that's class 3, versus the level really speaks to how many different types of patient populations has the intervention been applied to. Level A is really multiple different populations from randomized trials, versus level C would be very limited populations where we're talking about maybe consensus opinions or case studies overall. So I'm going to really focus on the class 1 level A, which, from class 1, these are conditions for which there's evidence for the intervention, general agreement that the treatment is useful and effective, and level A being that it derives from multiple randomized trials. So I'm going to speak specifically now. So what's the evidence with regards to the organization of actual healthcare services for patients with stroke to provide them with rehabilitation? So according to the AHA guidelines, there are several actual areas for class 1, although they vary with regards to the level of evidence. And so it won't surprise, hopefully, this audience that there is class 1 level A evidence to recommend that patients who are candidates for rehabilitation services should receive them. And of course, it doesn't, and we know there's plenty of discussion here about what's a candidate for rehab services. And so there is, of course, quite a bit of debate and different opinions about who should receive such care, who is a candidate. And that's an open area in this field. And then, as you can see here, with regards to specifically breaking out rehab services to inpatient or outpatient services, the level of evidence goes down. overall. And what's interesting here to point out is that for inpatient rehab services, the comment really is all about patients who qualify for or have access to the inpatient rehab services. Who qualifies and has access is a point of contention. There are diverging opinions in this respect on healthcare workers and who gets to make those decisions. And then as I continue down further here about outpatient care and services, you can see here again, there's even less consensus. And then I'd like to speak specifically now to ARM and upper extremity activity. So what do the guidelines say? Now, it's come out very resoundingly clear here that when we think about different interventions with regards to patients with different impairments or limitations in activity, the first area that I wish to mention is that there's clear evidence for the use of botulinum toxin for the treatment of spasticity. And what's being shown here are various different clinical signs of spasticity of the arm. These are different presentations that are being shown in these pictures. And on the right side are the various different references and studies in support of this treatment for spasticity. So this is, in my opinion, an approach or a treatment intervention where there's plenty of data to support its use. It's commonly practiced around the world. And so this is more kind of a clear example where there's a consensus. And then on the bottom, I show a completely different example that has a class 1A evidence or endorsement from the AHA, which is that all individuals with stroke should receive ADL training, activities of dependent living, activities of daily living, tailored to individual needs and eventual discharge setting. And the picture here is basically showing a patient undergoing evaluation for grocery shopping. And I think this is a way for a therapist to decide if the patient can go home or back to the community. It's a way to check various different activities such as balance and reaching and so forth. So there's general agreement here that all patients should undergo this type of ADL training very specifically. And then for other upper extremity, thinking in terms of activities where there's class 1A evidence, this is, I think, a very important one to bring up about functional tasks. There is this level of evidence that there should be a focus on functional tasks that are task specific, that the tasks should be graded to challenge individual capabilities, practiced repeatedly and progressed in difficulty. And many might refer to some of these aspects as a shaping protocol. And so what I show here from right to left is that the patient on the right, for example, needs a lot of assistance with these tasks for handling and scooping of materials. It involves a supination of the arm. Versus in the middle, you can see here the patient that needs some assistance in cutting an apple with an assistive device, but has some control here, more of a normal movement, for example, and compared to, let's say, on the right, certainly less assistance. And on the left is really somebody who's working independently, folding towels on their own, showing in that independence with fine motor control. Standing, of course, also increases the challenge as well. But these are all examples here of kind of task-specific activities. Now, if we take a different example of guidelines from Australia in the foundation, their focus is a little bit different in this regard. So showing these recommendations with respect to the arm, they emphasize progressive resistance training. So it's a little bit different in terms of how to think about activity. And that there is more of a focus on the intervention of constraint-induced movement therapy with regards to application of these tasks. So what's being shown in the pictures here are examples of a patient undergoing this constraint-induced movement therapy, or CIMT. And so what's important to point out here is that from left to right, what's being shown essentially are in A, really these are more gross movement type tasks here of being able to spread or the use of a knife, with the hand, while the good arm, the good hand that's being shown here is constrained, and it forces the use of the impaired hand. in a gross type movement. In B, there's more of a finer movement involved here in the pouring of water. C, you can see here the aligning of coins. And D is using a pegboard. And this is an increasing kind of difficulty of using fine motor movements of the fingers overall. But again, the emphasis is on the constraints of the good hand. And I think that, what's important about this overall is, again, that these are activities, but that the emphasis here is on the constraint side. I think both organizations certainly agree there's a benefit, to CIMT, although the American guidelines conclude there's conflicting information regarding CIMT, certainly that they say the evidence is favorable at class 2A. And so again, it's just really how the guidelines are put out and where the emphasis is placed around the tasks versus the constraint, and the importance of the intervention overall and its combination. The other thing to point out is that there are obviously many other interventions that can be applied in clinical practice, whether that's robotics, virtual reality. All of these other types of interventions receive lower classes of evidence overall. And so I just think that's important to point out in terms of review of all the literature that has been done. And then if we move from the arm to the lower extremity, one can speak about various different examples here as well. And so with regards to mobility, there's clear consensus from the American Heart Association that individuals with stroke should be provided formal fall prevention programs during hospitalization. And with regards again to botulinum toxin injections, consensus class 1A that there should be that type of intervention applied for patients with spasticity in the legs as shown and visualized in the figures that are being shown here for various different presentations of spasticity in the legs. And lastly, that individuals with stroke who have poor balance or have difficulty with balance should be provided with a balance training program. And just a couple of other aspects that are endorsed by the American Heart Association's guidelines that patients should be prescribed and fit, with assistive devices, orthotics, to improve balance. In addition to this, there's a couple of AFOs that are shown here just as examples of devices that are used to help patients with gait impairments and to improve their mobility. And lastly, that as expected, repetitive, intensive, task-specific training activities are recommended to improve gait overall. So I think, here, there's just various different examples that I wanted to show you where the guidelines are indicating that there's consensus for high-level benefit and high-level class of evidence. On the side of the Australian Foundation and the Stroke Foundation in Australia and New Zealand, their emphasis is slightly bit different, but there certainly is agreement about the use of task-specific activities. They speak very specifically about those with reduced strength should have progressive resistance training. So that is no surprise since they mentioned this for the arm, as well as just specifically thinking about walking. I just kind of just wanted to just show an example essentially of patients that go through the different phases of walking, and specifically with regards to the placement of the leg during the different phases of walking, because that's where the emphasis is placed with regards to thinking about different types of training programs. But the emphasis here is task-specific practice as shown through the different components of walking and where the legs are positioned as part of gait training. And so I just listed here where the similarities are versus the differences. Similarities are agreement about repetitive task practice, supporting resistance training, as well as several others. But where there are differences, AHA concludes there's conflicting information regarding circuit training specifically. The Stroke Foundation identifies lower limb orthotics as weak recommendations versus it's a 1A by the AHA. So while there's many commonalities, there are also some differences with regards to guidelines overall. And I think it's how one actually interprets the clinical trial data coming from various different studies overall. And last, I will just mention aphasia. that there is agreement that language therapy is and something that should be recommended for individuals with aphasia. There is specifically some interesting difference in recommendations that the Australian recommendations actually now include a proposed recommendation that aphasia therapy should be provided within 4 weeks of the onset of a stroke. There is no specific timing that is specifically endorsed at a Class 1A level by the AHA. So it was important, I think, to be able to at least describe to you where the Class 1A level recommendations are that's supported by clinical trial data, but perhaps more importantly is really talking about the areas where there isn't a lot of data yet. So I categorize here and going through guidelines the topics with weak evidence, and that includes things such as the prevention of a hemiplegic shoulder pain, which is very common that stroke survivors unfortunately endure. So you can see here, and I've listed here, what is the level of evidence that the AHA says that there is in support of different types of interventions. What's I think particularly interesting is motor assessments are considered to may be useful. And I mention that because, ISRRA and many other organizations are working on wanting to come up with consensus and have put out even guidelines around thinking about what are the outcomes that we should be thinking about in motor assessments. But, presently, when we think about it from the perspective of clinical trial data, it can only achieve this level here, the Class 2 in this regard. And I think a lot of this is consensus opinions. But it is something to consider or to think about where we might want to think about further clinical studies. And last is spasticity. Well, I mentioned botulinum toxin, that's a clear intervention, but other interventions for spasticity, we don't have the strongest evidence in support of specific interventions. And what about areas where we really have very little in the way of let's say, data from randomized clinical trials, but yet there are certainly studies that would help to support certain questions. But I could have, listed a whole number of different topics. These are just ones that came to my mind overall. But, and again, Julie Bernhardt had mentioned this, but, really, in at least in my opinion, we have a long way to go with regards to big topic questions on timing, intensity, duration of interventions, certainly for motor impairments, and even certainly more for aphasia, in various different time periods after stroke. I'm gratified, and it's great to see studies like AVERT and AVERT Dose that Dr. Bernhardt is leading, to see recent studies like CPAS that have recently come out by Dr. Dromark and his team at MedStar. And then you can see here a whole host of other topics that I've listed here. Chronic stroke, there's certainly a support for treatment effects from observational studies that have been led by Professor Ward, our moderator. And as I go further down the line here, I won't read all of these, but again, this is just a list that is a short one. There could be various other topics. And I will just put a plug in here that certainly for specific interventions like stimulation and pharmacological approaches to cell-based therapies, all of these are going through different phases of clinical trials that have a randomized nature to them. But even if we did hundreds more randomized clinical trials, we're still going to face other issues. That is that there will still be variation in how specific clinical protocols, different types of how interventions are applied, will be implemented for patients. We don't have consensus around the world with regards to how specific types of rehabilitation paradigms are applied to patients with arm impairment. I mentioned the GRASS protocol because Professor Ang in Canada, I'm very much liked this particular protocol for arm impairment as a protocol to improve recovery, but it's one of many different clinical protocols that have been developed for arm impairment. How will we achieve consensus with regards to implementation of specific protocols? Yeah, I think is going to be a challenge. And then, of course, the big question of how much evidence is enough, influenced by many colleagues, including our moderator on this question. Do we need to have our randomized clinical trial for every question? If in the chronic stroke setting, it's been shown through observational studies that the intensity, high intensity upper limb rehabilitation actually improves outcome in observational studies. Do we need randomized trials when the comparator for such studies would be essentially nothing? And so that's a question, I think, for the field that overall, we have to grapple with, but is an important one to consider. So in conclusion, there certainly are guidelines, and I'm particularly am very indebted that the American Heart Association brings together experts to update these guidelines, indebted to other countries. Australia in particular, Canada would be another, and many other countries that have their own guidelines with regards to reviewing the evidence base for stroke rehabilitation. And my hope is that this type of discussion and going through the evidence and the guidelines is that recovery will now be, at least for stroke, the next frontier for rigorous clinical trials and implementation research. And with that, thank you very much. Oh, and lastly, sorry, I'll just put in one more plug, sorry. And I hope that in the future, and this is just a plug, you know, for imaging, that we will have far more in the way of including imaging so we can actually visualize the anatomy of the injury. Most of our clinical trials that you can see in recovery and rehabilitation do not take into account, I think, where the level of the injury is located or the extent of the injury. So this is just one picture of tractography showing the stroke in red and the cortical spinal tract shown on DTT, tractography, diffusion tractography. This diffusion tensor tractography is what DTT stands for. And you can see here how the tracts really on the injured side are really thinned out and showing the tract at different levels, the corona radiata, the posterior limb internal capsule, and at the rostral pons. And so I hope again in the future that we will include this type of imaging because I think it certainly will help to enhance patient selection in our studies in the future. I will stop sharing my screen at this point. I can return back.
Okay, Sean, thank you so much. And thanks to all the speakers. So we've probably got about another, let's say 5 or 10 minutes. We've got a few questions that I think we need to get to. So I'm going to interpret the questions. I won't read them out line by line, but I'm going to start with a big one. And this was something that Fernando, who's a stroke specialist from Mexico, posted. And it's really about this issue of, I guess, you know, is this issue of the plateau of recovery. And, you know, we hear the phrase often that recovery stops a few weeks or a few months after stroke. So I have particular views on that, which I'll chip in with, but I'm gonna let you guys have a go at that one first.
So Nick, just to be clear, the question is about when does rehab stop?
No, the question is, what do you think about the phrase recovery? And patients, you know, patients will tell me, and I'm sure they tell you, that they have been told this by healthcare professionals that they should expect their recovery to stop a few months after they've had the stroke.
Mm-hmm. Well, I guess my own personal view is that you should never say that recovery would ever stop, and that people do have different timelines for recovery. It's important that people always have hope and that there's always something that can be produced. And your very own research from Queen Square illustrates that recovery goes on for some time. So I would say it never stops, really.
Sean, you got anything to add to that?
Well, I agree. I think that we need to stop thinking of the idea that there's no value in continuing to engage the brain from a timing perspective. I do perhaps think that there may be a different way to think about it, which is that the greatest opportunities, you know, could be in earlier stages after stroke onset. There may be more to gain, and we need studies to fully understand, you know, better those types of issues. But this idea that, you know, there's a plateau and that there's no further opportunity for recovery, I think we need to dispel that as a myth. And certainly, Nick, none of us want to speak for your work with regards to the really, I think, very encouraging data that indicates that the brain retains a capacity for recovery years out after stroke. Clearly, that's being shown through your studies. And I think we need to enhance that message as time goes on. We need to amplify those types of research projects. And I think we have a huge challenge ahead for many years to come to convince funders that the brain does have this capacity for recovery, years out after the onset of injury.
Yeah, thanks. I mean, I would agree with that. I think the simple way that I would kind of attack that, if somebody was saying that, is depends what you mean by recovery. So I think the controversy is always over recovery at the level of impairment. And I would say that, you know, some of our data show that impairment can change. You know, if you believe that in the chronic phase, what you're tapping into is the capacity for experience-dependent plasticity, as Fernando points out, why would that go away in a chronic stroke patient? There's no rationale for that. But then if you look at the other elements of the ICF, so activity and participation, why would you ever say that somebody can't benefit at the level of activity and participation at any stage post-stroke? Yeah. So in fact, the rationale for taking away therapies is entirely pragmatic and economic. It's not biological. And yet we see people pointing to those recovery slopes and saying, well, there's a plateau there, therefore there's no point treating. It's a self-fulfilling prophecy. So yeah, good question, Fernando. As a kind of follow-up from that, you know, we often talk about rehab aims to achieve the optimum recovery. I think we do have to acknowledge that not everybody is going to get back to normal. And so achieving the optimum recovery is a really important concept. How do we determine what is the optimum recovery in individual patients? This is great. I'm asking you these tough questions. Normally I get asked them, but
I mean, yeah. From my point of view, I think it's a purely personal thing. What you're hoping is to set clear goals with that individual that's meaningful for them, not meaningful for the therapist or for the rehab consultant. It's meaningful for that individual. And however you get back to that, it's as far as you can progress towards reaching the goal that the individual has set. So one of the things in the Centres of Clinical Excellence that we've set out is optimal outcomes for patients. And that's been a tough nut to crack in terms of operationalising that. And we're currently working on how we would describe what optimal recovery actually means. So watch this space.
Okay. All right, I'm just going to move on to some of the other questions, make sure we get some coverage. So Robin asked a question about different types of patients. So are there any studies or is there any evidence looking at rehabilitation needs and outcomes for specific groups? Quite difficult to get to groups like people who are homeless or people who are living in respite centres, for example. I don't have an answer to that.
I don't have an answer for that. I don't know, but it's an important area, and I would imagine that there's somebody out there somewhere researching it, maybe as a PhD topic. So it would be great to hear more about it.
Okay, so good question, Robin, but you stumped us. But it does speak to this idea that rehabilitation as a treatment is not a one-size-fits-all.
That's right.
So not only do you have to take into consideration what the combination of impairments is in an individual person, but you have to take into account their environmental influence, which is something that's embedded in the ICF anyway. Okay, so we have a question from Reggie Ann who says, what is the role of the nurse on an acute rehab unit?
So I think that one was, there was two questions come up, one for therapy assistants and the nurse role within ISRRA. The bottom line in a nutshell is that ISRRA is an inclusive alliance. If you have a passion for moving forward stroke rehab research and recovery and clinical services in that area, then we want you on board with us to work in all the myriad of initiatives. So please come on board. There's a role for everybody and also for patients and carers.
I'd say I read that question. I read the question slightly differently. What is the role of the nurse in rehab? So that's a different question. I mean, that is a very interesting question. It's particularly important because the nurse is probably the person who spends most of the time with the patient. So working within the multidisciplinary team, which I think sometimes you see nurses are not fully embedded in the MDT, I think is crucially important because of that.
Mm-hmm.
Okay, so Robin, I'm trying to interpret Robin's question. So Robin has a question. I'm going to give this one to you, Sean, and it's something about patients who get thrombolyzed, so TPA patients who go into intensive care. And I think there is a protocol, perhaps in the US, where non-TPA patients do not go to the ICU. And I think the question is about whether there's a difference in outcomes in those two groups. Sorry if I butchered your question, Robin.
Well, I mean, I think we've certainly clearly shown there's differences in outcome between those that receive TPA and those that don't. It's patients that qualify for TPA don't receive it. There's clearly a difference in outcome that's been shown through 25 years of clinical trials supporting the benefit of TPA.
But I think the question might be if the kind of if the pathway is different in terms of early acute rehabilitation. Is there something different about being kept in different environments?
I see. Well, that actually gets into some interesting questions and issues about mobilization of patients that have received TPA. And so there, in my view, there really should be no difference, that if the patient is ready for rehabilitation, and again, we don't fully know through Julie's studies exactly how early is too early, but TPA really should not be the defining characteristic about whether the patient should be undergoing a rehabilitation pathway. The reason is because the half-life of TPA is minutes. And so if there is concern about the patient's undergoing or getting the patient up from bed to start engaging in therapy or activity-dependent activities, we really shouldn't be so worried about that. If the principal concern is because they receive TPA. Now, if they go to the ICU, as is the custom of many stroke centers, although not all stroke centers that do patients with TPA go to the ICU, there are some that have an intermediary unit. That is true that they may be at a disadvantage about what types of rehab services could be started in the ICU. But I would hope that the patient who's deemed to be stable within those first 24 hours could then be moved out to what would be the next step down unit for such patients so that they can then start to undergo such therapy. But bottom line is we shouldn't be really seeing a difference in how these patients are approached when it comes to the beginning of therapy.
Okay. All right, going to move on to another question. So this one is from Debbie Miko. So Debbie has a patient who has a hemorrhagic stroke, which involves particularly primary motor cortex and premotor cortex. Now, she says that the patient is doing very well from the gait and balance point of view, nice power returning to the legs, but there's zero power returning to the arms. And the question is what's going on there. So the first thing is about the difference between infarcts and hemorrhage. And I have to say, we have great data on this, but our kind of observation is that there is something different about the recovery pattern of hemorrhage in comparison to stroke. You often hear it said to infarct rather, but you often hear it said that hemorrhagic stroke recovers more slowly, takes a little bit more time to get going, and that might have something to do with the resorption of the blood. And some people say that the blood is kind of toxic to the brain and it takes a little bit longer to get over that. I think the other question is about the anatomical localization. And I was kind of struggle a bit when I hear about patients who've got no motor signals at all going into the upper limb. You think about, well, where is that signal coming from? So if they've taken out their corticospinal tract, these patients should be relying on what's left of their reticulospinal tract. But of course, reticulospinal tract has input from both sides of the brain. So, and we know that the reticulospinal tract projects predominantly to the flexors. So you would expect at least to get some kind of flexor synergy pattern in a patient like this. So when somebody's getting no signals at all, then I struggle to explain that. So is it the case that there are signals coming down onto that motor neuron, but for some reason they can't be expressed? Maybe there's some loss of joint range, maybe there's some muscle atrophy, so it can't actually be those signals can't be used, or other signals just not getting down there. Any comments from you guys?
Simply, Nick, that I would just link that to a different, comment and question that you said before, which is essentially, what's optimum recovery? And I think, that this speaks to potential, and that we need to understand anatomy, I think, for these types of questions.
Yeah, we do. Yeah, but not just cortical anatomy, but the brainstem anatomy as well.
Right, yeah. Exactly.
Okay, Marion, this one's for you. What would be the best control to use in an RCT given the current state of post-stroke rehab?
So that's an excellent question, and one that's been definitely raised within ISRRA And I'm pleased to say that there's a current working group in ISRRA that is led by Kate Hayward in Australia, who's leading this piece of work. So don't have the answer at the moment to it, but there is current work looking at this, because often the control is difficult to define and often ends up not being a true control. So very good question. And the answer is, hopefully we'll know soon.
Yeah, it's a tricky one. Yeah. What do we think about patient-reported outcome measures as outcome measures for rehab treatments?
I think they're a great addition to our other standardized outcome measures. What the patient thinks, of course, at the end of the day is is the holy grail that we're trying to resolve. That's why we're in this business. We want to help people and make them feel better. So and improve their recovery. So I'm all for patient reported outcome measures, but also as part of other standardized assessments.
Yeah, I think it speaks to a problem that we have in rehab, in that traditionally randomized controlled trials are supposed to be designed with a primary outcome measure, the one that we're particularly interested in. And I think often the wrong primary outcome measure is chosen. But the reality is, as we've said earlier, we're interested in how people recover at different levels: impairment, activity, participation, emotion, all of these things. And so actually we should be measuring all of those. The trouble is, when you put all of those outcome measures into a trial, you often get criticized and told to pick the one that you're going to put all your money on, which I think is not quite how we should be doing things in rehab. Okay, so you're posting all your questions now. I haven't given me a chance to read them. Let's have a look. Dear moderators, do you think that the current WHO and AHA stroke definition should include long-term consequences? And would it maybe improve more complete care for patients and research in neuro rehab? Should definitions include long-term consequences? I think we should understand long-term consequences better in terms of definitions, I guess. Yeah, a definition is just a good way of operationalizing it. Marion, like you want to say something there?
No, I just agree. And there's a lot of work going on and looking at definitions of what we mean by long-term care. There's a lot of work come out of our unit in Nottingham looking at long-term and what we mean by that. And so yeah, I agree. It's about operationalizing services and support to deal with problems as they're ongoing. Stroke isn't just for a defined period. It's ongoing.
Sure.
The recovery.
What about our thoughts on the importance of responders and non-responders to specific treatments? Try and take account of the variability that we see.
I think people respond very differently to different things. They respond to individual people. They respond to different types of regimes. We know that polypharmacy, or personalized pharmacy, is coming more to the fore. I think we need to work out that for our patients. What do they need? What's the individual personalized care that they need?
Yeah, I mean, I think Sean, did you want to say anything about that before I?
No, I mean, I think it speaks to the fact that we I fully agree about how we're going to define what is a response versus a non-response, and some of that gets into what is minimal clinically meaningful differences on our scales, but then it also speaks to the fact that, of course, there's tremendous heterogeneity in this field in terms of treatment responses. So ideally, it's great to be able to handle these types of questions with large studies, so that we can do sub-hoc analyses, I'm looking forward to the future where we will have such funding to do big studies to be able to look for responders versus non-responders.
Yeah, I mean, I think one thing is that there just is natural variability in anything, in any kind of biological data. There is a distribution of outcomes, and so sometimes saying responders and non-responders is just referring to the fact that there is a distribution. I think the other thing is that if we have a known mechanism of action of a particular treatment, then you should target it to people who are likely to benefit. So stratification of patients based on a knowledge of either the anatomy of the damage or method, the mechanism of the intervention would be a much better way of doing trials. And otherwise, as Sean said, you're going to need very, very large trials in order to kind of deal with that variability. Okay, is there an upper limit of blood pressure that is safe for rehab mobilization to start? Sean.
You know, I'm when I come and I see patients in the clinic, I mean, it's interesting, you know, with regards to this. I'm not keen on, you know, patients that have very high blood pressures, you know, in general. It's something that I think we need to work on. You know, I don't think that there's a defined upper limits that we'd all agree upon, you know, with respect to, you know, this question. And I think, again, this is also on an individualized basis. If you have a patient who has chronic hypertension and is used to living with a blood pressure of systolic 180, you know, I think that's very different. You know, that's somebody who has a blood pressure that normally is in the 120 to 140 range. If they have chronic small vessel disease and that's the blood pressure they're at, that's just a very different scenario. And one in which I can imagine that it would still be safe for them to undergo certain types of rehab therapy, not all types. So I think it also depends upon the individual patient as well. But in general, I don't like pressures of something that would be systolics of 180 and certainly want them treated. But I would look at the individual patient with regards to that question. I don't think there's any one particular upper cutoff number that I would be looking at.
Okay, all right. There's one here on proportional recovery, which is obviously a minefield, so we can try and tiptoe through that. But the proportional recovery idea from a few years ago was that it was originally described for the upper limb and said that patients will regain about 70% of what they've lost. Now, you can go into the literature and you can find the review articles and the opinion articles that talk about the people who firmly believe that versus people who think it's not particularly the case. I think what we can say is that from the data that are available at the moment, outcome is generally has something to do with where you started off. So severity is if you look at all kind of models of prediction of outcome, initial severity is not a bad predictor, except what the proportional recovery studies did tell us was that we are really, really bad at telling how well somebody's going to do if they started off quite bad. So for example, in the upper limb, people with a Fugger of say 18 or less, some of them do really well and some of them do really badly. And currently, we don't have a great idea about why that might be. It might be something to do with the anatomy of the damage and whether the corticospinal tract is intact. But I think it speaks to this idea that we're not great at predicting outcome. And I think as clinicians, we kind of feel that we're not bad. And that's because the mild to moderate patients, it's not that hard to tell how well they're going to do on average generally. But the severe ones, we're pretty bad at actually. And I think we just need to bear that in mind when talking to patients. Anything to add, guys? Okay. I think we're nearly done. Last one. How do you see the possibility of using big data tools to research answers to many of the questions that remain in stroke rehabilitation?
I mean, we need big data. And the difficulty is sometimes pulling the data together and trying to have some common language within it. But I think, big data is definitely the way to go, and we could be doing a lot more with amalgamated data. I don't know, Sean or Nick, do you want to add to that?
Yeah, I would agree. I think there's a lot of potential for machine-based learning, AI approaches, deep learning. The problem and the challenge really is to be able to think about data that's collected in common data elements across various different centers, across different countries. There is tremendous variability with regards to what data is being collected. And so in order for us to apply big data tools, we were going to have some type of agreements among various different colleagues across different centers, across different countries to be able to do that kind of work. It's a dream that I hope that we would be able to all work together and do so. And so I hope and I look for that kind of future But you know, there's we think about informatics and all of the great work that they're starting to do here across so many different sectors of healthcare. So looking forward to it in the future.
My kind of brief comment on that is big data are still data, and you know, we need data, but in any experiment or clinical trial that collects data, they're only as good as the question that you ask. I'm going to leave you with that thought. Any experiment or any clinical trial, doesn't matter how well conducted it is, it doesn't matter how big or small the data are, if it's a bad question, it's a terrible study. So we need to ask good questions. I think making Marion laugh is
that's a nice ending, I think.
to end. So I just want to say thanks to all the speakers, to Marion, to Sean, and to Julie, who is probably tucked up in bed now. And thanks to Laura as our host.
Thank you so much. Wonderful discussions, great presentations and questions. I want to thank everyone for your warm participation in today's webinar. Thank you to our speakers and to our moderator for their precious time and for their contribution today. As mentioned, a recorded version of this webinar will be shared with you, as well as the instructions to claim your credits. In the meanwhile, make sure to follow the American Heart Association and the World Stroke Academy websites, as well as our Twitter and LinkedIn pages. And we look forward to seeing you in our next webinar. Take care, everyone, and thank you again.
Thank you. Bye-bye.
Bye.